Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
So tonight we're going to be talking about unraveling cancer genetics. And we have with us today Tamara Milagre from Evita. Tamara is a nurse and she's also the founder and president of Evita Foundation. And she also is the creator of a new platform called Evita Platform, which is an innovative digital platform to provide critical support to everyone who's concerned about their cancer risks and to cancer patients as well. Uh, and it's also available, of course, for the healthcare providers. Tamara has a very long list of things that she has done throughout her life. She is a representative of carriers of genetic alterations with predisposition to hereditary cancer in the European Reference Network Gentris since 2017. She has completed the European School of Medical Oncology with a master also in 2017. And she is the founding member of the Hereditary Cancer Working Group of the Brazilian Society of Oncology. And she has also received Scientific Merit Medal from the Ministry of Science, Manuel Heitor, in 2020. So she has vast knowledge in this topic. And let's start talking about this subject that is so very important to both professionals as well as cancer patients.
Thank you very much for your kind introduction, Sophia, and welcome everybody in the audience. I'm happy that you are interested in this topic because it's really important and our knowledge can save lives, basically. So we will talk about a short introduction regarding hereditary cancer. We will talk about facts and unmet needs in hereditary cancer syndromes. We also have some good news regarding that. Then we will discuss early detection is great, but prevention is better, of course. I will present a solution for the lacks identified and also talk in my conclusions. So hereditary cancer is a consequence of a genetic predisposition due to an inherited germline variant. Before they called it mutation, but the European Reference Network Gentris, Genetic Tumor Risk Syndromes, which unites some of the most relevant experts in hereditary cancer research, they decided that the naming should be variant instead of mutation. So, okay, there it is. Rare, it's the novo mutation. That means it is not inherited from one of the parents, but it started with the newborn itself. This is mostly the case in Li-Fraumeni syndrome, for example. The genetic variant carrier has an elevated risk to develop early onset cancer in a group of organs. So if we look at the BRCA2 gene, for example, they have an increased risk for breast, ovarian, prostate, pancreatic cancer, and melanoma. And also, each cancer is potentially involved in a panel of genes. In case of breast cancer, we're talking about the well-known BRCA genes. Because of Angelina Jolie, everybody knows the BRCA genes. The POP2, the P10, the STK11, TP53 is the responsible gene for Li-Fraumeni, for example, CHEK2, ATM, and so on and so forth. So around 10% of all cancers are hereditary. That is what literature says, but new data, new evidence is arising. At the same time, we actually do not have any data on hereditary cancer. In our National Cancer Registry in Portugal, there is not a unique case of hereditary cancer. They are all sporadic, which is completely impossible, but we will talk about that later. So only 20% of genetic variant carriers are identified. That means 80% are not aware of their genetic predisposition. And over 50% of hereditary cancer patients do not need testing criteria by current guidelines, and some do not undergo genetic testing. So we need to update our guidelines, and we also need to improve our communication because some people decide that they don't want to know. So if we look at Portugal, we have around 70,000 new cases of cancer each year. That means 7,000 of those would be hereditary cancer. So the three most prevalent cancers, already representing around 40% of all cancers, they are potentially involved within the two most frequent hereditary cancer syndromes, which is hereditary breast, ovarian, and prostate cancer, and Lynch syndrome, which is mainly colorectal cancer and endometrial cancer. A new gene for prostate cancer was just published the day before yesterday. So we are finding more and more genes, and hereditary cancer will gain more and more weight and importance in cancer research and in strategies for fighting against cancer. Even lung cancer is linked in some percentage to hereditary cancer syndromes. Nobody would tell a few years ago, but now we know it. So if we compare with Europe, we are talking about 450,000 cases of hereditary cancer each year. And the same statistics here with the involvement in the most frequent hereditary cancer syndromes. So this is a lot, and it's actionable, but we do not really act as much on it as we should. If a genetic variant carrier or the healthcare provider, if they are not aware of the genetic predisposition, first symptoms may be disregarded and delay diagnosis of hereditary cancer, which has, again, the biggest potential for prevention and early diagnosis. Our story of Evita is that I took care of a 27-year-old pregnant lady in a recovery room in the hospital because she had a mastectomy in our hospital. So when I was listening to the baby's heartbeat and looking at that young woman expecting her second child and thinking about her already very advanced cancer, I was really shocked, and I never heard about this. And I asked myself, what happened here? She is so young. I never heard about this. A 27-year-old woman with breast cancer. The same happened to her doctor, because I followed up her doctor appointments, and she told me she called the attention of her doctor in the beginning of the pregnancy when she already felt the lump. And the doctor said, "Child, you're way too young to get breast cancer. Those are changes from pregnancy." So that is our story. That is how Evita started. Because of this experience, I woke up for my own family history of cancer, because she told me 2 aunts on the paternal side had died of breast cancer in their 40s. And the same happened in my family. So she woke me up for the importance to know my own family history of cancer and to look for genetic counseling, because I have a very strong family history on the paternal side. So my paternal grandmother and 3 aunts died of hereditary cancer, as well as my father, hereditary prostate cancer. So I found quickly out when I talked to Germany that my mutation was on the father's side. But the story is not ending here. My mother also had breast cancer at 44, but there was no family history. There were no siblings. Just a maternal aunt of her had pancreatic cancer. So when she got her second contralateral multifocal triple negative diagnosis 30 years later after the first diagnosis, I called Germany and I told them, you need to do genetic testing on my mother because I have 4 nieces. My brother has 4 daughters. He is negative for the paternal mutation, and we need to check on the potential maternal mutation. And it came through that my mother also carried a BRCA1 mutation. So in my family history, there are all possible scenarios you can get in a hereditary cancer syndrome family, with family history, without family history, men affected, and so on and so forth. So due to early onset of hereditary cancer, during the peak of fertility and productivity, and often late stage diagnosis, because there is no populational screening for us, it's too late for us then. Hereditary cancer represents a high socioeconomic burden. We have first evidence on that in a national project called HBOC Effect. So it's about socioeconomical burden in hereditary breast ovarian cancer. How much does it cost to test the carrier, to follow up, and even with preventive surgeries, versus let the disease install itself and then have a second primary cancer and then metastasize and then die decades before it's supposed to. So, of course, we have our first numbers that prove what is the obvious. It's totally cost effective to prevent hereditary cancer. And on European level, we have the Preventable Project, which looks after the rarer hereditary cancer syndromes and what is it worth what is worth it, the prevention versus letting the disease install. Again, we are talking about one carrier and risk for multiple cancers. Don't forget about that. There's low genetic literacy in civil and even medical society. Involved specialists are often not aware. So the general practitioner who is in front of the family history of cancer is not really educated how to refer whom, when, to where. Also, dermatologists are involved in many syndromes. Remember the BRCA2 gene. Melanoma can be linked to pancreatic cancer, can be linked to prostate cancer. Dermatologists are not aware of that. And the other specialties outside genetics and oncology, they have really a strong lack of genetic literacy. I think that is the main barrier for timely referral of a lot of carriers. And then we would have a chance to raise awareness within the European Code Against Cancer, which is actually missing out on the highest risk factor, which is genetic predisposition. There are syndromes that guarantee you that you get cancer, like the familial polyposis. You will get colon cancer. So the complexity of all this hinders the identification of patterns and symptoms, and its information is very dispersed. Also, we need to look after the mental health because it's a family matter. Hereditary cancer affects each and every member of a family in different ways, but it does. And this impact on the mental health within the family is totally underserved. We have unacceptable waiting times for genetic counseling, genetic testing, surveillance, and prophylactic surgeries. We did a report in an article in a national newspaper in 2019 where we had 3 testimonies that got sick with cancer while they were waiting for their prevention. This is a strong failure in cancer prevention. Once you have cancer, you never again get rid of the fear that it comes back. I lived with that my whole life with my mother that got sick at 44. Inequity in care and treatment access. Not everybody has good access to genetic counseling, to genetic testing, or to target therapy. If we go back again to the BRCA mutations, they have target therapy available nowadays. PARP inhibitors are doing a really great job, but they are expensive and they are not available in all member states. There's no strategy and a very low budget on prevention and early detection. In Portugal, we have under 2% allocated to prevention. The healthcare system should be called a sick care system because prevention is really a stepson in oncology. There is a huge lack of patient and public involvement and engagement in health technology assessment and research. So patient centricity is not ensured. Now, specifically looking at Portugal, there is a Portuguese founder mutation in the BRCA2 gene, and it needs to be proactively analyzed. Otherwise, you cannot find it. So we got contacted by Portuguese immigrants from France that had a very typical BRCA family history and had cancer themselves at young age, and that genetic testing came back negative. So they asked us, what should we do? We all got cancer and we have a negative test result. And we told them, make sure with your doctor and the lab that the Portuguese founder mutation was done because it's a specific sequencing method that you can find it. So it leads us to call attention to the European reference network and ask the specialists to release a note on the Portuguese founder mutation and to run that specific mutation on anybody with Portuguese ancestry. So we won't have false negative results anymore because there are still lives at risk that can be saved if we have this knowledge. And Portugal, by the way, is the European champion in emigration. We have a population of 2 million people and 10 million people, and 2 million are emigrated. So that's a huge community outside Portugal. But now let's talk about the good news. Not everything is bad. So besides, the message here is knowledge is power. Know your risk, know your family history of cancer, because it's actionable. There are very good new technologies on the horizon. We are actually in the ongoing MammoScreen project involved with Evita. We are a partner. And this is a new device that works very well for young women at high risk, even during pregnancy, because it works very well in dense breast tissue. Dense breast tissue is the case for all young women and also over 40% of elderly women. That's also an important message. Know your breast density, because as an elderly woman and dense breasts, you also have a higher risk to develop breast cancer, not necessarily because of the genetic variant, but because of the dense breast. And then the mammogram cannot see very well through dense breast. This will be a white image, something like that. And this new device, which is called MammoWave, developed by Umbria Bioengineering Technologies from Italy, it has no radiation at all. It's totally female friendly, pain-free, and it's inclusive because not every woman with certain cultural background wants to put her naked breasts in front of a technician into a machine. So this device is a different one and will for sure be a big added value for the screening of young women at high risk for breast cancer. So then we have, starting now this year, 2 other European projects. There was, for the first time in history, a specific call on hereditary cancer syndromes to develop new biomarkers for early detection of heritable cancers. The European Commission had 33 proposals to evaluate. Free got finance, and Evita is partner in 2 of the 3 finance projects, very proudly, by the way. So one of the projects is on biomarkers for early detection of Lynch syndrome-related cancer, and the other one is a biomarker for early detection of hereditary ovarian cancer, which is still nowadays in 2025 one of the most deadliest cancers, because we do not have symptoms until we have late stage. So we are forced, when we are at high risk, to take out the ovaries at least 10 years before natural menopause. And when you have the early onset surgical menopause, you have a strong decrease of your quality of life. And I would ask you to send any question you could have in the chat, because we will have time to discuss afterwards. So early detection is great, but prevention is really better. Hereditary cancer has an enormous potential for prevention and early detection. Prevention may be achieved by risk-reducing surgeries. So a BRCA carrier woman, for example, would opt for oophorectomy, take out the ovaries. BRCA2 carrier should do that at 40. BRCA1 carrier should think about it at 35 already. And we also have pre-implantation genetic diagnosis. That means that the carrier that still decides to have children can opt for a fertilization in vitro, where they select afterwards, after 3 days in the lab, the embryo of 8 cells that is free of the mutation. So there are really nasty mutations. Like I told you, the Lee-Fraumeni syndrome gives you cancer all over your body, and starting even in childhood age. So that would be worth it to avoid the passing down of the mutation, no doubt about that. So you can have your children without the mutation, and it ends here with the hereditary cancer syndrome in this family. And nowadays, genetic testing is totally affordable. When I did my test back then in 2007, it cost still 3,000 euros. Nowadays, it's 200, 300 euros, not more anymore. And it's a test you do only once in your lifetime, or maybe twice if you have done it a long time ago. Everybody that tested before 2015, for example, should repeat genetic testing, because we are finding more and more genes. So the question is, are our healthcare systems prepared to offer personalized screening and follow-up? Because if you identify a genetic mutation carrier, you need to offer personalized screening. You need to do the MRI in young women with high risk for breast cancer, because, again, mammogram does not see anything in dense breasts. Ultrasound is not really a very valuable screening method. So you need to do an MRI each year. And then, but is that so expensive, or would it be better to let them get sick? I mean, for us, it's a no-brainer. If we prevent disease, we prevent waste for the system, and we save lives. I think with the socioeconomic studies, we can convince decision makers to change their strategy. How can we convince them? Yeah, with our numbers. They need numbers. They need to understand, okay, identify the carrier, pay for the testing, for the screening, and even preventive surgeries is still much cheaper than getting them sick. Again, it happens usually on the peak of fertility and productivity. And many, many years of productivity loss, and unfortunately, in some cases, losing their lives decades before it's supposed to. So, is it intelligent to let genetic variant carriers become sick? I don't think so. And while we are working on shifting the mindset, let's elaborate on how to improve the identification of genetic variant carriers. And that's our proposal, where we are working on since the last 6 years after identifying all the gaps and unmet needs in hereditary cancer. We started a citizen-to-citizen initiative, Evita platform, which is a GDPR-compliant digital platform with high standard technology and multiple features for anyone, especially those who are concerned about their cancer risk, genetic variant carriers already identified, and all cancer patients. Remember, we also want to get to those that have no testing criteria, but that still had hereditary cancer. And so the concept of this whole platform is the user is in charge, they are in charge of their health and their data. So nobody has any access to the data if it's not consent by the user. We have 3 profiles. It's the Evita user, so everybody who wants to learn more about hereditary cancer, who wants to get an idea. It's for healthcare professionals and for researchers. And I will elaborate more on that afterwards. So the heart piece of the Evita platform is our familial cancer risk assessment tool that generates an immediate result, a short questionnaire of 10 questions. They are based on national recommendations of our program of genetics and oncology of our Portuguese Society of Oncology. So you have these 10 simple questions where you have the possibility to answer yes, no, or I don't know. If you answer you don't know, we ask you to look up better your family history of cancer and do again the questionnaire. If you answer no to everything, you are, of course, not indicated for genetic counseling because there's no need. But if you have one question answered with yes, we advise you to look for genetic counseling, to dive deeper and professionally with a medical geneticist into the potential genetic testing. We have in our second phase, which is being finished in this moment, we will have a digital agenda available where you can book your appointment inside Evita platform. So again, in a safe space for genetic counseling via telemedicine. That will also shorten drastically the waiting times. So then when you get your result, and we advise you, you imagine you get the result that your risk appears to be elevated, we recommend you to have genetic counseling, and that is what I told you right now. We will have this inside the Evita platform. We are actually meeting with the Ministry of Health in February to discuss the potential uptake of the telemedicine part of Evita platform within the Ministry of Health. So it would be assumed by the national healthcare system, because we want everybody to have access to this kind of telemedicine that is accurate and quick and informs you quickly. So let's see if we are lucky regarding the Ministry of Health. And we also tell you that it's highly recommended that you repeat the tests whenever you uncover new information regarding additional cancer cases in your family, of course, because you can have a negative result before, but then it's more important to take, again, when you have a new cancer case in your family, you should undergo again the questionnaire. So, what else do we offer right now in phase 1 that was launched last year in February? We help you with health literacy. We have lay summaries of scientific articles. We have newsletters, and we promote webinars. We give you information regarding clinical trials recruiting in Europe. In Portugal, we have great doctors and researchers, really great, but we are not doing very well with clinical trials. We need to attract more clinical trials into our country. We have some people that go to neighbor Spain because Spain is doing really well. And when you have an advanced cancer diagnosis, you want to travel from Portugal to Spain to have access to innovation and potentially improve your health. So the very important clinical area also already working is a secure space for uploading the entire clinical process in a centralized manner to overcome the barrier of lacking system interoperability and to prevent waste, duplication of exams and analysis, and also the bother. So imagine you get your cancer diagnosis in hospital A. You undergo chemotherapy in B. You have surgery in C and radiotherapy in D. And they do not communicate with each other. You have your process all over the place. And there are even hospitals where the first floor doesn't communicate with the second floor. I mean, it's ridiculous, but it's true. And I know it's true in all other countries because, it was done like that, unfortunately. And so we give you the possibility to upload all your reports in a safe space with encryption and data protection, where you have it always ready to show to your doctor in any hospital where you are. It's in your phone. And then we also created a clinical diary with the possibility of granting access to your authorized oncologist so they can prepare better for the next appointment, optimizing the limited time, which is a kind of telemonitoring, The doctor knows that you took medicine X on Thursday and you had diarrhea until Saturday. So he knows he needs to look up an alternative. And when you come to the next doctor appointment, he's already prepared and can give it to you. So this is a artificial intelligence painted as a beautiful female oncologist reading a book. So they may even have time to study more and educate themselves better about hereditary cancer syndromes. So in phase 2, we will have ready the digital agenda, the telemedicine, the app, and we will have our user profiles of healthcare professional and researcher. So the oncologist, as we saw, with prior authorization, will have access to the information selected in the clinical diary. It's also a communication channel. So if the oncologists want to leave their messages, he can do so. I know that some doctors give their personal phone number out to patients, but not everybody is not everybody is up to give out the personal mobile phone number because otherwise they would not sleep anymore, right? So then, for the geneticists, these are the healthcare professional profiles, the geneticist has a reserved area for video consultation and for genetic counseling. And we also have psychological counseling in the same manner in a reserved area for video consultations. The researcher can put the researcher questions with target audience selection. So we have the demographic data. They may want to know how many women do you have with a BRCA1 mutation at the age between 30 and 40, for example, and we can select this information, not the BRCA1 mutation, but we can invite them with their demographic data to take part in the study. And then again, the user is in charge of everything, decides if he or she gives their informed consent or not to participate in the research study. The report output with structured data we can give for anybody interested. There is access to the reservoir of previous research. You can look up what others had asked to the data pool in a Evita platform. And we will be able to perform PROMs, so the patient-reported outcome, the post-reported experience measurements. We will produce real-world evidence and real-world data. So we have already first data available. We are close to 2,700 registries. 74% of those took the risk assessment questionnaire, and here comes our unmet need. 83% of those who took the risk assessment questionnaire had in fact elevated risk results. So 907 filled in the demographic data and family history of cancer in my profile. Surprise, 82% are women. Again, men are very difficult to reach in health communication for health literacy. They are, I would say, kind of afraid to learn about possible cancer risks in the family. So women are, most of them are mothers. They are worried to see their children growing up and so on and so forth. It's a different species. So 186 of our registered users are cancer patients. And again, no surprise, half of them are breast cancer patients. So in conclusion, to address the unmet needs in oncology, particularly in hereditary cancer, we must leverage Evita platform that empowers patients, healthcare providers, and researchers alike. By offering tools for personalized risk assessment, health literacy, centralized clinical data management, and telemedicine, we can enhance patient engagement, improve care coordination, and streamline communication. Integrating these solutions ensures more efficient use of consultation time, reduces unnecessary medical procedures, and provides timely access to genetic counseling and psychological support. We are embracing the FAIR principles, findable, accessible, interoperable, and reusable within Evita platform because we aim to integrate systems like the European health data space and will further enhance data interoperability and research collaboration, driving better outcomes for prevention, early detection, and quality of life of hereditary cancer patients. And with that, I thank you very much for your attention, and I'm really happy to answer any question you may have. Thank you.
Thank you very much, Tamara. I'm waiting to hear if anyone writes any questions here on our platform. But meanwhile, here's a question. At what age would you suggest that people should start testing if they do have a family history of cancer?
So the big part of hereditary cancer syndromes develops cancer at an adult age. And there's also something like the risk not to want to know. So if the syndrome does not involve childhood cancer, genetic testing in underaged is not possible by law because they have the right to not want to know. Uh, in the other syndromes, you can test as soon as you are an adult, 18 years up, but I think it's important to look at the age when the screening should start and do the tests a year before or something like that, because you want to build up your life, you want to finish your school, your studies, you want to start to work, and you want to maybe to buy a house, you need insurance, and you do not want to make obvious that there is a genetic hereditary cancer syndrome in your family. I mean, it's important to say that private insurance companies are not allowed to ask for any genetic information. But I mean, if you take your shirt off and you have no breasts but two big scars, and they ask you what happened here, what should you tell? You didn't have cancer. Okay, I did a preventive surgery. Why would that be? And so on and so forth. It's quite a complicated thing. But again, if it's not affecting children, you can only test when the patient or the person is 18 or elder, and it's their own decision. The parents are for sure very nervous. They want to know as soon as possible if the children inherited the genetic mutation, the genetic variant, but they need to stand that out.
No, of course, that makes sense. And there has to be a certain type of maturity as well, correct? And in terms of, I mean, if a person is to do genetic testing, it makes more sense to do it when there is a direct line, correct, with cancer. So a mother, a sister, brother, father, correct? And pass out, would a person, I mean, would a grandparent also be within that line?
Of course, of course. Any family members in the same lineage, if you observe multiple cancers at young age in the same lineage, then you should have genetic counseling and genetic testing. Yeah. Normally, how it works nowadays is that usually a family member is diagnosed at a young age with cancer. And then not only because they want to know about syndromes, but also for decision making process, the oncologists ask for genetic testing because maybe if there is a syndrome, they can offer the patient to do immediately the double mastectomy with the reconstruction and so on and so forth. And also, like I told you, the PARP inhibitors are working very well in BRCA carriers. So that is how it starts nowadays. But we at Vita, we want to change the mindset and allow also healthy people, because there are many healthy people, they may not speak to family members, they may not have survivors alive in the family of cancer. Yeah, they need to have their genetic counseling at least, and then see if the geneticist asks for genetic testing, because it's the geneticist that decides that. And we really would like to bet more on prevention than on remedy. And I mean, once cancer, it never again comes out of your head that it can return at any moment. I saw it. My mother was really the whole years. She was so in panic every time she went for the follow up, and we thought, you must chill. You are great. I mean, hair grows back, and everybody thinks you are brilliant, you are excellent, you are totally healthy and fine, but it's not the same like it's inside you. I felt this very closely with my sweet mommy. Yeah.
I understand, and I totally agree with you on that. Um, Here's another question. I'm going to be, throwing a few questions just for people that are listening to understand a little bit more. For example, let's say someone has a primary cancer, um, in the breast, for example, and then they years later they get another primary cancer in another organ, and they did do genetic testing the first time, would it be smart for them to redo the genetic testing because there are different types of testing to be done?
Yeah, as I said, so there is no official recommendation, but our specialists at Genturis, they are talking like everybody that got tested before 2015 should repeat it, because we found many more genes in between. I mean, before they only looked up the BRCA gene, and now we have dozens of genes that are related, for example, to breast cancer. And then you have syndromes where you can get stomach cancer, When your first diagnosis was a stomach cancer, nobody at the time would remember that it could be related to breast cancer risk and so on and so forth. So it is important, if there went already a certain time from the first diagnosis to the actual diagnosis, then yes, I would always discuss this possibility with my oncologist.
Okay. And in terms of, mostly with the healthcare providers, I mean, what can we do for them to also to be more informed about genetic testing and counseling?
Excellent question. That's an excellent question. You're really so we thought that with our risk assessment questionnaire in Evita platform, we can also help non-specialists. They can do the questionnaire with their patients and understand if they should be referred to genetic counseling. Okay. And ideally, we have it available immediately inside the Evita platform. And ideally, our national healthcare system assumes all that part and so on and so forth. So it's so complex. It's impossible to know all the different scenarios in all the hereditary cancer syndromes. There are really very rare syndromes also involved. So this is very difficult. Our questionnaire is in that way structured that we can catch any type of hereditary cancer syndrome. Because, as you said, for example, only the fact that one develops two primary cancers, that is already indication for genetic counseling and testing. So, and the counseling should always happen before the testing, because a genetic test result has consequences, and you need to understand before you undergo that genetic testing what are the consequences. Our message at Evita is always the good one, the positive one. Knowledge is power. It's a good thing. You know why everybody in your family had cancer and why some of them died in early ages. That's a good thing, because you can end it. It can end, as I told you, the pre-implantation genetic diagnosis avoids passing down the genetic mutation. So it's over. It's a good thing. But people need to slowly understand and grow in there together with decision makers who are still a little sleepy about this very, very important topic.
Yeah, of course, I understand that. And I'm sure, of course, just as you said, pre doing the genetic testing, there is counseling. And I'm sure that there is also counseling, or there should be counseling after the results, whether they come back as with a positive or negative, correct?
Exactly. So unfortunately, the handling is not well structured on national level. Different institutes handle it in different ways, but there are high risk consultation clinics that have always a psychologist present when they give the result. Yeah, the result is also it's not clear black or white. We also can have a variant of unknown significance. Those are really a big pain for the doctors, because you don't know how to interpret that. So They may lead their screening options for this patient regarding existing family history. So there is a family, there was cancer along the family, but there is no clear identified variant. But okay, because of the family history, we do a follow-up as you would be a genetic variant carrier. And then there is the other case where there is no evident family history, and then they may opt for giving them, release them from the clinic, So that's still a difficult thing, but I think artificial intelligence will help us to reclassify much quicker and better in the future the variants in pathogenic or benign. So that's a big hope also for the future.
Perfect. I was checking here if anyone else had any other questions, but I don't see any other questions. So
I talked so clearly they understood it all.
wonderful. No, I guess so. No, it was very interesting topic, and it's an ongoing topic, of course, that needs to be very much talked about, brought up, especially with the doctors as well, the healthcare professionals, so that much as you were talking about, prevention is key here. So the sooner we can have the information in our hands, the more we can know how to target.
Yeah, absolutely. Knowledge is power.
Thank you.
Thank you for having me. Lovely to
Thank
talk to you. And bye bye.
bye bye.